me invite Dr. Dinesh. He'll be talking on the role of anti-VEGFs. Dinesh, all yours. And I think we can have an interactive session at the end of the session. Thank you.
Hmm? Yeah, no audio. Hmm. Thank you, Ajay, for inviting me to be a part of this course. Um, and now we come to, after the basic epidemiology, we come to the management with anti-VEGF agents. This is my disclaimer and financial disclosure. Now, diabetic retinopathy is not one condition. It is a continuum from preclinical retinopathy all the way to advanced end-stage diabetic eye disease. And the treatment points for diabetic retinopathy actually start at the stage of no retinopathy, which is with medical treatment. And then as the disease progresses, the next stage of treatment um, jumps in, but the previous one doesn't stop. So you don't stop medical treatment because you're going on to the ocular treatment, and then you need ocular treatment for both for maculopathy, PDR, and the sequelae of PDR. Now, before we go further, as far as diabetic maculopathy is concerned, I want one concept to be understood, and that is that when we talk of center involving macular edema nowadays, we are forgetting that the center involving macular edema may have its leaks somewhere more than 500 micron from the foveal center, which means it is then amenable to laser. By missing this critical point, we actually end up skewing our treatment towards more and more injections and forgetting the role of laser altogether. So even if you're talking of anti-VEGFs, don't forget this. Now, both the Restore and the DRCR net protocol I showed us that anti-VEGF treatments work, and they actually gave a misconception that anti-VEGFs alone are better than a combination of anti-VEGFs with laser, suggesting that laser treatment is actually deleterious for the treatment. But just to show you this subgroup analysis of the same study, you see that if you've done a focal macular laser, there is no difference between laser plus anti-VEGF versus only anti-VEGF. On the other hand, if you're going to do a grid laser in diffuse diabetic macular edema, the vision drops and the outcomes fall down. So the fall that you see in the previous slide is actually attributable to treatment done for grid by grid rather than by doing a focal macular laser. Focal macular laser gives you both the benefits, decrease in number of injections, as well as maintaining the vision. So don't forget that. Now, which anti-VEGF to use when? The protocol T gave us a lot of information on this. It compared aflibercept with ranibizumab and bevacizumab, showed that aflibercept was definitely better, though the difference between the first year and second year came down. However, what is more striking was that in patients who have poorer vision, the poorer the vision, the better the effect of aflibercept. So it stood out as compared to the other drugs when the vision dropped. In patients with good vision, all the three drugs seem to have the same visual outcome. But before you say that all of them were identical, make a note of this. Diabetic macular edema, your objective is to reduce the edema, and with bevacizumab, that reduction is almost half of what you get with ranibizumab and aflibercept. So even in your good vision patients, you don't start with bevacizumab, you start with ranibizumab or aflibercept. In patients who have poorer vision than 612 at baseline, there is no question that the best drug is aflibercept. Even more important is the fact that that if you see the effect of 3 consecutive injections with aflibercept, around half of your patients will get better than 2-line improvement. Now, those who get this improvement are actually elite responders, and they will not need a switch to any other alternative drug. So you know by 3 injections whether this patient is going to stay well on this treatment or not. On the other hand, there are going to be another 25% of patients who've got less than 5-letter improvement. Now, these are the patients who need to switch. Rather than waiting 6 injections, 7 injections, continuing indefinitely, this is the way probably to go. Now, if you were starting with ranibizumab, the elite responders number something like 25%. So that's the difference. So the 25% who respond to ranibizumab, you definitely don't need to do anything else, because these patients with 3-4 injections will become all right for the whole year. Now, the other important thing is that when the central subfield thickness is very high, more than 400 micron, aflibercept is probably the best drug to use. In patients who have the edema less severe than that, less than 400 micron, both ranibizumab and aflibercept are similar. But you'll have patients who can't afford all these drugs. Now, the patients who can't afford these drugs, laser treatment, when given in conjunction with ranibizumab and bevacizumab, gives you the same degree of drying as aflibercept as monotherapy. So the patients who can't afford monotherapy with aflibercept can be tackled by a combination of these 2 drugs. The other important thing is you get these patients who got better than 6/12 vision, 6/9, better than and N6. Now you say, do we need to treat them? Well, all this time I've been saying for many years, these patients don't need treatment. Just follow them up, and if they deteriorate, you can treat them. The protocol V actually says the same. You could not get better results by treating these patients even with aflibercept. You got the same results as those who were managed conservatively. So the best approach is continuous monitoring till you see early signs of deterioration, and then you can initiate the anti-VEGF treatment. On the other hand, if you get patients who have a decrease in either distant vision or near vision, now you see the point to be added here is near vision. We forget, all the studies talk about distant vision. The fact is, if your near vision has got down to N10, the patient still needs treatment. So both decrease in near vision and distant vision are indications for treatment with anti-VEGF agents. The treatment is PRN from initiation. This is not a loading dose. It could be that the patient needs 3 injections, he needs 5 injections, he may need only 1 injection. But it is not a loading dose of 1, 2, 3, 4, 5. It is a PRN from initiation. Continue to give monthly till the patient reaches a normalization of the foveal contour with normal vision. And then you can stop treatment and follow up. But if this endpoint is not reached, then you need to continue the treatment. And I would say that if you have 2 consecutive injections after your first 2-3 injections, and there is no change, then this patient needs to be tried on steroids. As far as proliferative diabetic retinopathy is concerned, you have a combination of lasers, anti-VEGF agents, and steroids available. The protocol S said, hey, anti-VEGF agents are great, better visual outcomes, less loss, better fields, but PRPs are not without advantages. Fewer visits, fewer injections, more cost effective. But even more important, in patients with diabetic macular edema, and people never talk about this, those who had only monotherapy needed more injections, whereas those who had combination with PRP had half the number of injections, thereby in a very big study telling us that doing a PRP decreases the macular edema too. It is not just effective for treating the PDR. The more important thing is that when you treat with monotherapy with anti-VEGFs and the patient doesn't come for follow-up, you end up with vitreous hemorrhage, neovascular glaucoma, and tractional retinal detachments in a substantial number of patients. And in fact, in one of the studies, 50% of the patients ended up with vision of hand movements or worse, because he's under the feeling that nothing needs to be done. Now, So what is the way to go for these patients? Probably the best way is a combination of anti-VEGFs with PRP. And there was a study called the Proteus study which actually showed that yes, this combination is better than only PRP. You get better regression of total regression of neovascularization with the combination rather than in PRP alone. The Pride study compared monotherapy also and found that the best results were with monotherapy. Within 3 months, everything regressed, but it came back. By the end of the year, 17% of patients had recurrences. Combined therapy, long term, nothing was left over. So recurrences are more following monotherapy. Laser may be better for high risk PDRs, and combined therapy gives the most sustained results. So today I would follow up for treat these patients, raise neovascularization, complete the laser first, anti-VEGFs later, flat neovascularization, laser prior to or soon after an anti-VEGF treatment. And if you still have NVE persistent after adequate laser, this is the best group for anti-VEGF treatment now. And we'll come to the role of monotherapy. I believe monotherapy with anti-VEGFs is like catching a tiger by the tail. You've caught it, now you can't get off it. So the best way is not monotherapy unless you explain to the patient that this patient now may require 14 or more injections in 2 years with the possibility of more later. It doesn't finish there. You still need regular follow-ups. If you don't follow up, you'll end up with the secondary glaucomas and TRDs, which I talked about. And so if your patient says, I want monotherapy, I will come month after month, follow me up with that, go ahead. Ladies and gentlemen, judicious use of anti-VEGF agents as part of a multi-pronged attack can definitely help to preserve and improve visual function in patients with diabetic retinopathy, possibly even indefinitely. Thank you very much, ladies and gentlemen.
Thanks, Dinesh. That was wonderful. I think we'll save the questions for the end so that all speakers can give their talks. I will call